Welcome back. This is Ian Bodford.
And Liang Liu.
And this is the Clinical Correlation.
Today's case is...
There's a snake in my boot!
This is a 45-year-old male who checked himself into the ED because he is having swelling and pain to his left hand.
Earlier in the day, he was clearing a brush pile with his hands when he felt a sharp pain on the palm of his hand. He did not think too much of it at first. He thought he might have scraped his hand on a branch and gotten a splinter. However, when he got to the bottom of the pile, he discovered a bed of snakes.
On exam, you can see there are 2 distinct puncture wounds surrounded by ecchymosis and swelling.
Unfortunately for you and the patient, he is unable to provide a great description of the snakes because as soon as he saw them, he took off running.
I mean, wouldn't you?
The first step in treating a snake bite is determining whether it is venomous or not.
That girl is
Several characteristics about the snakes help us make this determination. One of the first things you can do is inspect the bite, looking for fang marks, as in our patient. Unfortunately, sometimes the swelling and local tissue destruction makes this difficult.
If your patient saw the snake and can give a description, or better yet, brings in the snake, venomous snakes tend to have a more triangular head when looking from above.
The key exception to this is the coral snake.
Venomous snakes also have elliptical pupils compared to the round pupils of non-venomous snakes. And finally, many of the venomous snakes have heat-sensing pits, just inferior to their eyes.
Around 5,000 venomous snake bites are reported to the Poison Control Center in the U.S. each year.
Good thing we aren't in Asia.
Snake venom is a mixture of proteins, peptides, lipids, and metal ions.
Keep in mind that around 25% of venomous snake bites are dry bites and no venom is injected.
But this bite site was oozing, so it was probably envenomated.
Many patients are unable to identify any features about the snake that bit them. So what are we looking for? Snake bites cause a wide array of symptoms. Literally, every system can be affected. If a patient is bitten by a snake and has any symptoms, be wary about this bite being venomous.
So you've determined that your patient has been bitten by a venomous snake. How are you going to work them up and treat them? This depends on the type of snake.
In the U.S., we have 2 families of venomous snakes, the Crotalids and the Elapids.
There are 3 different types of snakes in the Crotalid family: the rattlesnake, the cottonmouth, and the copperhead. There is only one type in the Elapid family, the coral snake.
If you are suspecting that your patient has been bitten by a venomous snake, it is a good idea to involve the Poison Control Center as soon as possible.
First, let's talk about the Crotalid family.
Crotalid venom causes local tissue destruction, hemolysis, and coagulopathy.
The venom contains metalloproteinases and hyaluronadases that cause swelling and damage to capillaries. If enough venom is injected, they may experience nausea, vomiting, oral numbness and tingling, dizziness, and muscle fasciculations.
If envenomation is even remotely suspected, obtain a CBC, coags, fibrinogen, fibrin degradation products, and chemistry panel.
Absence of any local injury, hematologic abnormality, or systemic effects 8 hours after a bite likely indicates a dry bite, though in rare circumstances this is not the case.
As with all wounds, local irrigation and a tetanus update are warranted. You should also remove all jewelry which could become stuck due to swelling. Elevate and immobilize the limb and be wary about compartment syndrome.
There's an antivenom for crotalid bites called Crofab. It is an antibody to the venom obtained from the serum of either pigs or horses. Due to the cost of the antivenom, up to several $1,000s per vial, it should not be given unless the patient meets certain criteria.
These are 1. Progression of swelling, 2. Abnormal labs, specifically platelets and fibrinogen, 3. Systemic manifestations of either altered status or hypotension, and 4. Neuromuscular toxicity.
Keep in mind that no studies have shown reduction in mortality with administration of antivenom. However, it does help with progression of pain and swelling. It also reverses the coagulopathy, improves hemodynamic instability, and symptoms including fasciculations and nausea and vomiting.
The initial dose is 4 to 6 vials for both adults and children. The initial infusion goes in over 1 hour. The patient should be reassessed after this infusion and labs should be rechecked. If there is continued progression of swelling or worsening of labs, a second loading dose should be given.
If symptoms and labs are improving, move on to maintenance dosing. Maintenance dosing is 2 vials at 6, 12, and 18 hours. Keep in mind that maintenance dosing is regional and snake specific. Consult your toxicologist to determine whether further doses are needed.
Be warned that due to the fact that the antibody is derived from animal serum, allergic reactions are not uncommon. Be prepared for the worst. If receiving antivenom, admit the patient to the hospital.
In the U.S., there are 3 types of crotalids.
First, the rattlesnake. Rattlesnake bites contribute to a majority of venomous bites in the U.S. This is likely due to their wide range as well as being farm-raised for their skin and meat. There are 36 species of rattlesnakes. They rarely bite unless provoked and give a stern warning by shaking their rattler. If treated promptly, their bites are rarely fatal.
Cottonmouths, or water moccasins, are found in the southeastern United States. When antagonized, they coil their bodies and open their mouths wide, displaying their fangs and white mouth, which attributes to their name. They are usually found near water, like marshes, lakes, and streams.
Copperheads are endemic to the eastern part of the United States. There are 5 different subspecies of copperheads. They are typically ambush hunters and are masters of camouflage, which likely leads to the number of bites in humans.
Next is the Elapid family. Their venom does not usually cause much local tissue damage.
Delivery of the venom is typically via chewing and not by injection. The effects may not be seen until hours after the bite. The venom can lead to a consumptive coagulopathy similar to DIC. It can also cause renal failure and hypovolemic shock.
The neurotoxicity involves local numbness rather than pain. It affects the cranial nerves and can cause respiratory depression. The photo of the man here shows ptosis from an Elapid bite.
To work these patients up, you should obtain a CBC, coags, fibrinogen, fibrin degradation products, CMP, and CK. An ABG can be obtained if there is respiratory depression.
Make sure to take off all jewelry that could become stuck due to swelling. Elevate and immobilize the limb.
All Elapid bites need to receive antivenom. However, it can be hard to find in some regions due to the rarity of the bites. It is a horse-derived antibody, so be prepared for allergic reactions. The initial dose is 3 to 5 vials. The additional doses are only given if symptoms occur. All patients require admission, even if symptom-free.
The only Elapid we have in the United States is the coral snake. There are 16 species of Old World coral snakes and 65 species of New World coral snakes. They are reclusive by nature and spend most of their time buried in the foliage on the ground.
Some species of non-venomous snakes have developed similar banding to coral snakes as a mode of intimidation for predators. A good mnemonic to remember is red on black, friend of Jack. Red on yellow, kills a fellow. This refers to the banding of the snakes. If the red and yellow bands touch, the snake is venomous.
However, this is not true for the coral snakes found in Mexico, so if you are south of the border, all bets are off.
Let's go over some myths about snake bites. You will not be able to suck out the venom. Do not try it. You run the risk of exposing the wound to the germs in your mouth and causing a bacterial infection.
Applying a tourniquet is effective at preventing spread of the venom, but this is exactly what you don't want. Spreading of the venom helps to dilute it. If it all stays in one place, it worsens the local tissue damage, but does not prevent the systemic effects.
Exposure to cold temperatures reduces blood flow to the area, and once again the venom will remain concentrated, causing local toxicity.
In summary, in patients reporting a snake bite, use clinical exam and description of the snake to determine whether it is venomous or not.
Keep in mind the difference between the Crotalid and Elapid families. The Crotalids cause local tissue damage first, prior to systemic effects, while the Elapids cause neurotoxic effects. And don't forget the antivenoms.
Always enlist help of the local poison control center. Call 1-800-222-1222.
So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
And me at EMLU.
Thanks for listening.